Right. Hello, and thank you for joining us for today's virtual education program at Kansas Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Chemobrain. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join a community, please visit our website at cscsouthbay.org. Without further ado, I'm going to introduce our workshop speaker. Dr. Arash Asher is the Director of Cancer Survivorship and Rehabilitation at Cedars Sinai Samuel Oschin's Comprehensive Cancer Institute, where he runs a dynamic clinic for patients and survivors. Dr. Asher has integrated a number of innovative cancer rehabilitation programs, including art therapy, personalized exercise regimes, and novel cognitive rehabilitation for Chemobrain. Thank you so much, Dr. Asher, for being here with us today.
Thank you so much. I appreciate the opportunity. As I'm often in the clinic, so for me to get a chance to come, and albeit it's not in person, which would have been my first preference and choice to sit down in a conference room, but at least to get a chance to talk to you all, this is always a great joy for me to try to bring things down to earth and hopefully give you some practical strategies that you can take. So I'll be happy to try to take questions as we go. I would ask that if it's of a deeply personal nature that only applies to your only your situation, maybe save that for maybe you could send me an email or a message. But if it's something that is applicable for others in our community, by all means, if there are points of clarification, this is all for you. So please do feel free to just ask questions as we go. So I'm going to bring up my slides. I've entitled this Roadmap to Cognitive Health After Cancer. I know this is a big challenge as one goes through this whole cancer journey and thinking about cognition. So what are the symptoms? I don't have to tell you what the symptoms are. Of course, many of you, or I assume all of you, have experienced some of these where we have a harder time with short-term memory, not usually long-term memory, but things that might have happened an hour ago, remembering names or dates or phone numbers, having maybe some more challenges with concentrating or staying focused on a task. Something I hear a lot is this idea that I used to do 2 or 3 things at once, right? I could drive and be on the phone and keep an eye on the road, and it's harder to do 3 things at once. And so needing to just do one thing at a time seems to be important. Slower processing speed or slower time processing information, or perhaps the most common one, there's a word on the tip of my tongue and I just can't get that word out, right? Like word finding challenges. And not everyone has every one of these issues, right? Some people just struggle in one area, some people in more than one area. The reality is, even though the lay word for this is so-called chemobrain, it's not a great word. And one of the reasons for that, and I could be wrong, but I'm going to assume that not everyone in this room, in this virtual room, that not everyone even had chemotherapy, right? I have many patients that have just had radiation or hormonal drugs or surgery or a combination of these other treatments, and they may still experience some of these cognitive symptoms. So there's no single symptom. There's no one size fits all. It's not like cholesterol where you can check your blood and have an objective measure of these symptoms. But because of these various factors that may be playing a role, the preferred medical term is, and you may have heard this, is CRCI, cancer-related cognitive impairment, because what it implies is that there's something related to the cancer or cancer experience as a whole that may have brought these symptoms to the forefront. The things that we just talked about, the word finding, the multitasking, etc. And by the way, let me just pause for a second. I'm going to share all the slides with Rebecca and the team, so I wouldn't worry about having to, take your time to take notes on what's on the slides. If there's something I say that resonates with you and you want to write that down, by all means. Although again, it's recorded as well. So hopefully you'll be able to sit back and just take things in. The first point I want to bring up, and this is, in my mind, an incredibly important one if we want to holistically manage Chemobrain or CRCI or whatever you want to call it, is thinking about what I view as the myriad of factors that may be contributing to our cognitive health, right? So hopefully you see a purple box in the middle, which is the Chemobrain box. And you'll see all these different factors which I believe contribute to CRCI or Chemobrain. I'm going to start, and I'm going to go through this just very quickly because I think, again, having an impression of the breadth of issues that may play a role actually may help us recover because it will help us focus our attentions on the things that we can control. So top left, cancer treatment, right? So that's the obvious one, right? They call it Chemobrain because maybe it's the chemo, right? Maybe it's the radiation, maybe it's the anesthesia from surgery. But there are other factors, right? The hormonal changes. So I imagine, could be wrong, but many of you in this room might be on things like Arimidex or tamoxifen. And for some, not everyone, but for some, this may be contributing to some of the cognitive symptoms. And while we're here to talk about, cancer-related cognitive impairment, it's important to remember that, if I have, heart issues and liver disease and kidney disease and other medical thyroid problems, sleep apnea, right, that may play a role. If I'm in a lot of pain, right, anyone who's experienced significant pain knows that when you're in a lot of pain, it's hard to think clearly. It's hard to focus and attend. Or other medications like some nausea drugs and maybe some antifungal medications and some sleeping medications and other medications that were used, steroids sometimes, right? All of these might sometimes contribute to some of the cognitive symptoms. But as we look further for a moment at this image, poor sleep, if I had to guess, half of the people in this room are not getting either enough sleep or enough quality sleep. So, and we know that poor sleep is implicated in cognitive symptoms. We'll talk about this, depression or anxiety or chronic stress or poor nutrition or lack of exercise or losing muscle mass and body composition changes, right? All of these things may not be experienced by everyone, but many experience more than one of these so-called bubbles. And all of them might contribute to how our brains are functioning. And you'll notice there's one kind of bolded item in bright yellow. And I bolded that because many experts in this space believe that these cytokines are a primary driver of these so-called chemobrain symptoms. Does anybody have any idea, and feel free to just unmute if you do, what are cytokines? Anybody have any idea? Has anyone heard that term? And I don't expect to have anyone know what they are, but I will tell you, everyone has experienced them. Everyone has experienced cytokines. So everyone here at some point in your life has had a bad flu or a really bad cold or a COVID, for example, right? And if you think about it, for those 2, 3, 4, 5 days when you have a bad flu, think about this. How do you feel? And I think invariably, most of us will say that we feel exhausted, right? We feel a little sad or blue, possibly. And if I asked you, does anybody want to take a textbook and study for a midterm while they have the flu? And I think we could all agree that the answer is no, right? Nobody wants to study for a midterm or really think deeply and concentrate when you have the flu because of how we feel. Now, it turns out when we have flu, or let's say we had COVID, it's not the flu virus itself that makes you feel tired, exhausted, a little sad or blue, foggy in how we're thinking mentally. It's not the virus itself, it's our immune system response to the flu. And it seems that our body, while it's making antibodies, produces these cytokines, we believe, at least in part, to intentionally make us feel crummy and foggy and exhausted and sad. And think about it, and think about this from an ancestral perspective. Why would our body be doing this to us? Right? Why would our body presumably intentionally make us feel so crummy? And as you think about this, somebody unmuted. You had somebody want to answer, Deb?
Would say because it's a way to make you slow down, stop, and give your body a chance to heal.
Precisely. And I'm going to repeat that just to make sure everyone heard it, right? If ancestrally, if I felt extraordinarily well when I had the flu, right, I'm going to keep hunting buffalo and gathering nuts and berries and chopping wood and doing whatever else, we did. It's only because I felt so terribly and crummy that it compelled me to stay at home in the cave resting so we can deal with the virus. I hope that makes sense, right? And then when the flu virus got better, then the cytokines would go down and we go back to hunting and chasing buffalo, right? I hope if that doesn't make sense, please pause me, but that's the basic idea of how ancestrally we were wired.
Would one of the symptoms maybe be a fever? Would that be one of the objective things that you could note for the cytokine?
So sometimes, absolutely, you would have fear. That's another part of what we're going to get to the term inflammatory process. But for our purposes, and this leads me, I think, nicely to the next slide. One of the prevailing theories for us here is that it's these same cytokines that our immune system produces in response to either the cancer cells or the chemo, radiation, and surgery. Think about the chemotherapy for a second, right? You have these drugs going through your vein, and your body is responding in the way that it knows to respond. What does it do? It sees some foreign substance being pumped through our body. And what does it do? It does what it was built to do, just like it did with the virus. It produces cytokines to make us feel, you see the terms here, cognitive symptoms, cognitive impairment, fatigue, maybe for some people, some symptoms of depression. And by the way, psychological distress, according to many models, adds to that cytokine production process. So whether it's the chemo, the distress, the anxiety, surgery, radiation, the cancer itself, or other factors that we were alluding to earlier and with that slide with the bubbles, they all seem to be creating the stew that produces cytokines and produces cognitive issues. Now, to the point that we were making earlier, when we have the flu, or even if you had COVID, and right, how many days, right, do we have the flu for typically? 3, 4, 5, maybe a week, days. How many cycles of chemotherapy did we have? For over how many months? And then how many weeks of radiation? So you see where I'm going with this, right? The cytokines were just temporary with the flu, but it keeps building on itself when we're going through these prolonged treatments. Now, I should pause for a second. I want to make a point, and this is more if you're interested in like I view myself as a complete nerd in this space, but when I started in this space 10, 15 years ago, many of the oncologists 15 years ago, especially 20 years ago, would say, you know what, Chemobrain's not real. And they actually had a very good reason for saying that. And the reason for that was they said, this is a kind of a cartoon. Up top are your neurons. This is like your brain cells up top. And the point they made is that we have this so-called blood-brain barrier. Okay? So in other words, we have this wall that protects the brain. And the point that they made 20 years ago was most chemotherapy drugs cannot cross this wall. And they were right, because mostly they do not. But the point that I'm here to make right now is that even though the chemotherapy, for the most part, does not cross the wall, you see the little purple circles here? These are the cytokines, IL-1, IL-6, TNF-alpha. You don't have to worry about what they are. Don't worry about that. They can cross the blood-brain barrier. So even though the chemo's in our veins and it's in our periphery of our body, and the production of these cytokines mainly be in the periphery, they do cross the blood-brain barrier. And again, for weeks and months and months. And so that we believe, at least in part, maybe a significant part, might be driving Chemobrain or CRCI. I hope that makes sense. So what do we do, right? The first point I want to make, and I think I'm going to make it again later. So most of you in this room, I have not had the opportunity to meet, and I don't know your individual story, but I would say, first off, if you're in treatment now, or if you recently finished, it's important to remember that time alone may help reduce these inflammatory cytokines and allow our brains to heal. For example, and I've done a number of so-called Chemobrain studies, interventional studies with our programs and whatnot. One of the things that I had a hard time with for our own Chemobrain program that I'll tell you about towards the end is, we would invite, the first grant I wrote, I said, we'll invite people to join the program within 2 months of them finishing chemotherapy. And the reviewers didn't like it. And the reason they didn't like it was they said, many of the symptoms may get better on its own. So they want us to wait at least 6 months to invite people to participate in research studies, because the argument was just 6 months. It's different for each person, 3 months, 6 months, 9 months. Those first months with just time alone can allow the brain to heal. Not for everyone fully, but it is an important part of the healing process. What I'm here to talk about is some of the things we can do to catalyze that healing process, right? And support that healing process. What about drugs? They are used on a case-by-case basis. Things like methylphenidate, which is Ritalin, and modafinil, and some of the Alzheimer's drugs. Bottom line, almost all experts were agreed there's really no good evidence across the board that these drugs are helpful. So I'm here to tell you that, at least for what we know today, I wouldn't wait for a magic pill to solve the types of issues that we were talking about at the beginning. So this is kind of, in my view, our roadmap for brain health and wellness after cancer. And it encompasses many facets. So in our program, that we have a 10-week program that we run now, there's a number of strategies, like mindfulness strategies. It helps with attention and anxiety, learning strategies on how to manage our negative thinking patterns, because I could tell you, the more negative thought, because we had a hard time during chemo, and if those thinking patterns stick for months and years afterwards, that's not going to help our attention and concentration and memory. There's a number of lifestyle ideas, and that's what I'm going to talk about for the most part today, approaches that can help. And again, there's all kinds of cognitive rehab strategies, from attention, problem solving, memory, et cetera, that may be helpful. So I cannot do all this. It's a 10-week module. I'm just going to give you a few high-level snippets of things to consider. And because we are offering our program virtually more often than not, given where we are in the world, right? If somebody's interested in the full program, you can contact me later. But I hope that the tidbits I'm going to go over for now will be useful to you. Okay, so point number 1, let's think about exercise and cognition. And I used to think that when we talk about exercise and cognition, we're really here to talk about brain games like Sudoku and crossword puzzles and that kind of thing. And, Sudoku, if you play Sudoku all day long, week by week, you'll get better at Sudoku, okay? It doesn't necessarily mean that that's going to translate to the everyday challenges that brought us to this space. So we're really talking about physical exercise because the evidence to support the role of exercise in cognitive recovery really is quite significant today. One of the points I want to make in this space, very briefly, is reminding every one of us about the idea that not all fat cells are created equal. And I'm being simplistic, but we basically have two types of fat. Subcutaneous fat, which is kind of like underneath our skin, right? And then so-called visceral fat. That's the fat that's deeper in the gut, around the liver and the pancreas and whatnot. It turns out having higher levels of this visceral fat in the general population is associated with all these issues: cardiovascular disease, heart disease, cognitive impairment, and maybe even some cancers. Even if your total body mass index is normal, we're still not off, we still are at risk, right? You don't have a clean slate there either. So let me tell you about one quick study that I think, at least to me, this was an incredibly eye-opening, kind of easy study. Let me walk you through this. I know it's a bunch of gibberish right now. So this is a study where they took healthy adult college students who were active, and they defined that by they were walking 10,000 steps a day or more. Active young adults. And they put them through an MRI machine so they could accurately measure their visceral fat. That's the bad fat. And what I know, we're not radiologists here, but you see the little white here? This is the liver over here. The white that you see is the bad fat. So they were able to measure the visceral fat very accurately. Then they had these otherwise young, healthy, college students go 14 days, 2 weeks of being a couch potato. And after 2 weeks, they put them back in the MRI machine. And this was the eye-opening part for me, and I hope it will be for you. You could see one individual, the amount of visceral fat that increased after. You could see the white here around the liver. On average, there was a 7% increase of visceral fat, intra-abdominal fat, in just 2 weeks. There was a decrease in fitness. There was a decrease in lean body mass in just 2 weeks. Why am I even talking about this here? Number one, again, remember, visceral fat seems to be a risk factor for cognitive symptoms. And number two, they were couch potatoes for 2 weeks. What if a well-intentioned doctor told you, you're going through chemo and radiation. It's a lot. Just take it easy and rest. It's important to just stay in bed and rest for these months. And by the way, it's not such a far-fetched idea. That was kind of the standard of care in the 70s and 80s and maybe even the 90s, was and I fear to say some people even hear that message I hear now, where chemo's a lot, just stay in bed. And we know that when we're doing that, our body composition is changing, and that may be changing how our brains are working. So long story short, even though exercise alone may not be the best way to lose weight when you look at the scale, it is a great way to change our body composition and reduce visceral fat. Okay? So we know with exercise, you can reduce visceral fat. The other amazing thing about exercise is it turns out that, remember a few minutes ago, if you just joined, let me just make this clear. We established this idea that one of the prevailing theories about Chemobrain, or CRCI, is that these cytokines are driving CRCI, that it's contributing to CRCI. And visceral fat produces cytokines, so it may be driving it as well. Well, we used to believe, until not that long ago, that muscle is important for what? That we need muscle so I can lift things and push things and get dressed and walk, and because of its mechanical functions. That was the prevailing theory. That's why we have muscle, so we can do things, physically. Which is true, of course, but we learned that when you do a squat, when you walk, when you do a curl, when you swim, and you contract your muscle, It's amazing. It turns out that muscle also produces something. And so, again, when you exercise, and this is a little cartoon of a muscle fiber, your muscle produces these chemicals, we call them myokines. It kind of sounds like cytokines, and I'm being a little bit simplistic about how the pathways work. But long story short, when these myokines are produced by muscle, what do? They reduce those cytokines. Now, I don't have a slide for this. So I'm just gonna stop sharing and just speak to you directly because this is actually an important point. So let's go back to our ancestor that we talked about at the beginning. We talked about this idea that that ancestrally somebody had the flu, right? Somebody had a bad infection. Inflammation, we said, went up, and we said that was appropriate because it gave our ancestor guidance to stay in bed because you're going to feel terrible. Now, after hopefully the flu was dealt with, right, and a week went by, a few days went by, and our immune system handled the flu. What would our ancestor then have gone on to do after that? After hopefully the horrible part of the virus was kind of contended with. What would they do? Any takers?
They would start doing their regular activities.
Exactly, right? I mean, they had to survive. So once the worst part of it was over, they went back to chasing buffalo again, which means they were contracting their muscles, which means they were producing myokines, which means it would reduce the cytokines. And as you can see, then we had an incredibly elegant system where we are going along, we get an infection or an injury, inflammation goes up, okay? We feel bad. And then after the infection hopefully gets better, we go back to moving our bodies, contracting our muscles, and then that brings inflammation down again. I hope you realize that where I'm going with this is with today's lifestyle, right? We get an infection, inflammation goes up. I may stay home for a couple of days, but after I feel better, I come back to work, which means I drive, right? I sit in the car and I come to work and I sit behind a computer all day long. So inflammation goes up, but it doesn't fully come down in the way that it was designed to be for hundreds of thousands of years. Because why? We're sitting around all the time. We're not moving our bodies. So this is a long way of me saying that exercise is a natural anti-inflammatory. It's a natural anti-inflammatory in a way that nature created for us, or God, or whatever your personal way of viewing this is. It's a way of regulating all this. And I think it's a way that we have to be mindful of even when we're going through surgery, chemo, and radiation, as long as it's safe for you in a way that makes sense. Well, hopefully we'll talk about that. I'm not going to spend much time on this. These are just studies showing that when you compare to a control group, when you do these randomized clinical trials, exercise, that's the bar in red, it improves, this is a 6-month intervention, it improves executive function, processing speed, memory, all these things improve with aerobic exercise, as opposed to the blue, which was a control group. So the bottom line, and this is not just coming from me, this is coming from every major national guideline, that cancer survivors should try to aim for 150 minutes or more of moderate aerobic exercise per week. And ideally strength training twice a week. Well, I'm not going to talk about strength training today. That's for another time. But I at least 150 minutes of moderate aerobic exercise. Keep in mind, before I shift topics, it's not black or white. So it's not like if you don't get to the 150-minute mark, you're not going to get these benefits, which by the way, includes the very real possibility of decreasing the chance of recurrence from many cancer types, including breast and colon, prostate, by anywhere from 30 to 50%. So not only does it help our brains recover, but it may very well reduce the chance of the cancer coming back. but to my point, it's not like if you don't get to 150, you get none of these benefits, right? 120 is better than 10, right? Or 90 is better than 30. So there's a gradual onslope. And in fact, going from getting no exercise, if you happen to be in that space, like 0 minutes to 20 minutes a week, to let's say 40 or 50 or 60 or 90, you actually will see the most, based on that increment, the biggest bang for your buck. So it's not all or nothing, but again, most experts will say you should aim for at least 150 if you can. Okay. Any questions about exercise for the group before I go to another topic related, which is going to be sleep and cognition? And we could always save it for the end as well. Okay. Sleep and cognition. In case there are any doubters, this has been shown in many different studies, but on a very simplistic level, this is one way to think about how we're doing is how many car crashes we're getting in. Across the board, this is not for cancer survivors, but across the board, if Americans get less than 4 hours of sleep, they have almost 12 times the rate of car accidents. I want to make you realize that even getting 5 to 6 hours, which is probably where many Americans are living, that still almost doubles your risk of a car accident. So there's this very clear idea that sleep is important for how our brains are working and how we're able to consolidate information. There was this amazing study, I can't believe it's 10 years old now, but this is one of those paradigm shifting studies where, and I'll put this into English, where we realized how important sleep is for our so-called brain cleanup. And there's this idea that we have our lymphatic system. So many of you heard of lymphatics, which clear out the gunk from our body. So for example, if some of you may have developed, for example, lymphedema after having some lymph nodes removed, it's hard to clear some of the toxins from that arm because the lymph nodes were affected. It turns out there's also a lymphatic system in our brain that clears out all the kind of debris and toxins from our brain activity. But what this study showed was that the lymphatic system is working much more efficiently when we're asleep compared to when we're awake. So if we're not sleeping well, we're not getting rid of some of these neurotoxins. So that's another example of how important sleep is. And this is, to me, this kind of nailed on the head. This is a study from a couple years ago where they had individuals rate the severity of their Chemobrain symptoms. So from none in blue to, well, excuse me, the y-axis are the patients who reported cognitive issues. The x-axis was how much insomnia they had. So the group that had virtually no insomnia, you see, they had relatively less likelihood of having cognitive symptoms. But the worse the insomnia got, you could see there was a very clear correlation, which is again another reminder of how important sleep really is. So I'm gonna talk about, somebody asked about melatonin. So let's talk, and again, in our program, we spent a whole hour. I'm only gonna spend 5 minutes on sleep, but very briefly, what are a few things you can do to try to manufacture the best sleep? And I'm here primarily to talk about natural sleep without medicines, because that's not a category I have time to get into right now. And this is going to indirectly answer the melatonin question that I got a moment ago. So these are just my personal suggestions based on the science as I understand it. So theme number one. Remember, for, again, hundreds of thousands of years, we've all had our natural biological clock regulated primarily by being exposed to light during the day, coupled with darkness at night. Now, this system has been completely mucked around with on both ends of the spectrum, because during the day, we're all inside, right? We're indoors, we never get any natural light. We're in, we're working, in offices and whatnot. And then at night, when ideally it should be really dark, and I guess, and all of us, I know this is the South Bay, but we're all in an urban area for the most part, and until you've gone camping in Death Valley or Joshua Tree or something, we forget how dark the night sky really is, the little bit of it that still exists in the world. But again, for hundreds of thousands of years, our clocks were regulated by, out light during the day, darkness at night. So one thing you can do to try to optimize, and by the way, the reason why this is related to melatonin, our bodies often will produce melatonin and release it naturally if you're getting these things, light through your eyes during the day, coupled by darkness at night. So that will really help our brains produce melatonin and release it naturally. So that's one idea. The second idea is remembering a common pattern that almost all of us are vulnerable to, especially when we go through prolonged stressful times. So here's how I see things happening. We're due for a scan next week, and I'm stressed out, I'm worried. That's the normal thing to feel for many of us, right? And when we're stressed out and worried, what do? We sleep poorly because we're tossing and turning and we're thinking about things, right? And then when we're sleeping poorly, again, we're tossing and turning and we get frustrated because we want to sleep, but we're not sleeping. And that frustration leads to the next night, right? The next day, we think about sleep. And what do? We think about sleep and remember what happened the previous night and the previous night. And so that actually leads to more frustration and more negative feelings because remember what happened the night before and the night before that, which actually leads to actually worse sleep. And then that leads to actually more stress. So you could see many of us are susceptible to this negative cycle, right? Of stress and getting into this negative pattern of sleeping. I'm not going to go through this in great detail, this next slide, because it's gonna take too much time, but you can look it up. You have the slides. One way of breaking that pattern is utilizing a therapy called stimulus control therapy. By the way, I wouldn't do this if you're in the middle of chemo radiation or whatnot, because it might be too hard to engage in these exercises. But you're going to have the slides. It's really readily available online as well, but I'll have it recorded. But this is one approach to break that cycle without medications. And what it basically does, I'm not going to go through the steps right now. Excuse me. What it basically does is it teaches your brain to take the frustration and negative thinking patterns and take that to the kitchen or the family room, and to have you associate the bedroom with just relaxation and sleep. Because what's happening with this pattern that I showed you here is consciously or subconsciously, our brains begin to associate that when my bed hits the pillow, my head hits the pillow, that's when the light goes on, I'm going to start thinking and worrying, and all those thoughts start churning out. It happens invariably to many of us, and we want to break that pattern. And again, one way of doing that is with stimulus control therapy. Stimulus control therapy, I should add, is one part of a larger program called Cognitive Behavioral Therapy for Insomnia, or CBTI. And virtually every sensible sleep expert today will tell you that this is the first thing we should try for insomnia, again, according to all of the latest guidelines. You may or may not have heard of it, but everyone will say that CBTI for chronic insomnia, assuming, again, there's not something else going on like pain that's waking you up or restless legs or sleep apnea, but if it's just this negative pattern that's developed, CBTI. And it includes stimulus control that I talked about, includes other approaches, including something called cognitive restructuring. I'm not here to, go through it all right now. Keep in mind, there are therapists in the community that have training and expertise in CBTI. I will also mention that there are online programs that are relatively, they range, but they're generally quite inexpensive. And recent research has shown that they can be probably just as effective as working with a therapist one-on-one. Typically, these programs are meant to be 5 to 7 sessions, 5 to 8 sessions, not lifelong type things. And I think it really can make a difference for many. Other ideas, and these are less evidence-based, but again, it might be worth trying. For some people, acupuncture. I think there's some evidence, I know there is some evidence for yoga, which of course, these are the types of programs that places like the cancer support community we're so lucky to have them in our backyard, in our community, because this is where I turn to for leaning on offering some of these types of programs: yoga, tai chi, qigong, meditation, spending time in nature, prayer, muscle relaxation. All of these things might help, increase the activity of our parasympathetic, right, our rest and relaxation nervous system, and decrease the sympathetic nervous system and help us sleep. But the things that are non-controversial and very evidence-based are here. Stick to a schedule, even on the weekends. We often forget this, but it could take 8 hours or sometimes more for caffeine to get out of our system. So be really careful about any kind of caffeine in the early or late afternoon, or certainly the evening. Alcohol, I realize alcohol helps some of us fall asleep, but the quality of the sleep often is not better. It reduces REM sleep, which is important for our memory. Try to avoid taking naps after 3 p.m. because it may interrupt sleep at night. A hot bath actually may be quite helpful for many. One, it relaxes you, but two, it also reduces our core temperature down, which is really what we need to help fall asleep. And along those same lines, most sleep experts will say that, I know we all want it 74, daytime, nighttime, summer, winter. We want our temperatures regulated. But again, ancestrally, it was meant to have cooler temperatures when we sleep, and that facilitates the sleep process. Many will argue around 65 degrees. Again, not for everyone, but for many is the ideal temperature. And again, the reason you don't want to be in bed but awake for more than 20 minutes is because that's when those negative associations and patterns take hold. So you want to take those thoughts to the kitchen or family room. Okay, I'm going to go over one other idea. And again, our program is 10 weeks. I just want to hit one more idea to give you something to think about, and then we could stop for questions. So I'll ask this question to the group. What increases the risk of death as much as smoking cigarettes, and more than inactivity, and more than obesity? Anybody have a guess they want to throw out there? Any takers?
Does negativity enter into it?
Sure. I mean, I think that's definitely could be an issue. Similarly, I would say some people guess depression or anxiety. But if we look at the research, and Deb, do you want to take a guess?
Social support group.
Exactly. Loneliness is the word really I'm looking for. And not even loneliness, I would add chronic loneliness. We all feel lonely sometimes. That's normal. That's what it means to be human. But when we experience loneliness month after month, year after year, decade after decade, that's where the science is showing that it can change in a negative way our cardiovascular system, our immune system, our nervous system, how our brains work. This was that study from a decade or so ago, which showed that, this is on the x-axis, the impact these different conditions had on our longevity. And so, for example, being obese, you could see had this much here. Being obese had this much of an impact, or exercise had this much of an impact. Well, you'll notice here, smoking 15 cigarettes had an impact of about 0.5, analogous to having low social support. I know it may be hard to see, but the bottom line is highlighted right here. I'm going to leave this up so you could stare at this for a moment. Chronic social isolation and loneliness seems to be equivalent to smoking 15 cigarettes a day. It's sobering. It's sobering for me to talk about this, after having just gone through the pandemic. And by the way, the study was done before the pandemic, right? So we were learning these things and it's not just the US. The UK, right? The UK before the pandemic, I think 2018 or 19, because this is a Western society issue, developed a ministry of loneliness because of the recognition of the impact loneliness, first of all, how common it was getting, and number two, the impact measurably it's having on our health. And the reality is, and I hate to share these kind of things, but I don't want to hide from the truth. Loneliness is a risk factor for cognitive decline, poor executive functioning, poor cognitive performance. And we did a study in our group that it also seems to be linked to Chemobrain as well. Now, before becoming too alarmist about this, I want to make an important point. Loneliness and isolation are interrelated, but they're not the same thing. Somebody could be married and have lots of people around them, but feel profoundly lonely. We all know that that can happen. And we all know that there are people that can live, all on their own, but they just have, a close cousin or a close neighbor or somebody they can call, or somebody, just one or two people in their life that they feel close to. And that's all they need from feeling loneliness. So it seems like it's the loneliness piece that might be the most important thing. And of course, I get it. Loneliness often leads to isolation, or isolation leads to loneliness, but they're not necessarily the same thing because of what I just said. Some people can be socially isolated, but not lonely. And again, some people are lonely even when you have 800 Facebook friends, right? So it's important to remember this. Now, why do I even bring this up here? Number one, I hope I made the case that it's been linked. Again, more work needs to be done. It's been linked to Chemobrain symptoms. But two, I wouldn't have brought it up if we felt like you couldn't overcome loneliness. As long as we realize, number one, that it is a health issue. It does seem to be equivalent, as I said, to smoking 15 cigarettes a day. And again, I know I'm just speaking to you one time for just 1 hour, which is just a one snapshot. But my hope is that if we remind ourselves that this is important, not just for our mental well-being, but it's been linked again to heart disease and dementia, and maybe even some cancer types and infections and whatnot, that will motivate us to connect to the people that mean the most to us, right? And that's another reason why, again, I think programming such as what's available at CSC is so important, because a big part in my mind of what they're offering is that social connectivity piece that I can't overestimate how important this is. If that's not enough, if that kind of that reminder is not enough, for some people, some therapy to kind of re-examine their relationships might be useful. But one of the great researchers who did a lot of this really cutting edge research on how valuable social connectivity is, not just for our mental well-being, but our biological health. He had this great quote. He said, because it really highlighted where we are. He said, the degree of social connection that can improve our health and happiness is both as simple and as difficult as being open and available to others. And so, again, this was all before the pandemic. Here we are in 2024. And I know we have to be creative in figuring out what social pathways make sense. I know we're in a divided, crazy world right now. It doesn't take away whatever's going on in the world. It doesn't take away that, again, I keep coming to this theme. Ancestrally, we were meant to be part of a tribe. And whatever we can do to kind of be consistent with our ancestral drive, I think that will help our health as well. I want to give, as I close, you know, I've rattled on just a few ideas in 40 minutes or so. We go through this in great detail in our 10-week Emerging from the Haze workshop. We run this generally 2 or 3 times a year. If there's room, you know, we usually cap it around 15 people. Sometimes we go a little bit over. You know, we open this up to the larger community outside of Sinai whenever there is room. So I do want to just put that out there because we do offer this often on Zoom, as opposed to making people come in person. Now we have the capacity to bring people a little farther out, including the South Bay. The other quick thing before I close for questions, and I'll look at the chat in a minute, is if you're interested, we are about to open a study in the next couple of weeks, actually. I think it's going to open in early mid-February. Is a little bit outside the box. This is a pilot study of photobiomodulation for these Chemobrain symptoms. There are certain criteria that need to be met if somebody qualifies for that study that's about to open. The basic idea, this is like just a cartoon image, that this helmet that produces light, it's basically light therapy. So you just come into our clinic, you would be exposed to this light twice a week for 6 weeks, and we're going to investigate whether this light therapy can improve some of the cognitive symptoms. The reason we're doing this study is because there's been some recent research that PBM is photobiomodulation, this light that I'm talking about, has been used for helping cognition for people who have had depression or mild traumatic brain injury, but there's been no research for CRCI or Chemobrain. So that's why we're undertaking this small pilot study. This is actually in real life, how that helmet looks. So one would just come in, you'd sit in a chair, put the helmet on for 20 minutes, and so that's how it works. So the contact information, well, you could email me if you're interested, and if you think you might be interested, if you think it might be able to qualify, and the criteria are here. You have to have finished chemo, again, as I mentioned to you, at least 6 months ago, but not more than 5 years ago. Stage 1 through 3, solid tumors or Hodgkin lymphoma. Those are the basic ones. There's some other fine print that we would go through. So if you're interested, feel free to send me a message. It opens up in about a month. We're only going to be able to enroll about 30 patients before we close. My contact info is here. So if I could be helpful, let me know. I'm going to stop sharing now so I could look at you all. And actually, I want to look at the chat. So let me start with the chat and see. So the melatonin, I'm not going to get into because I know some people use it for purported anti-tumor properties, which I'm not going to get into here. It's not the right setting. And for some people, the supplement helps them sleep. My personal bias is that if we start with what I talked about, getting light during the day and coupled at night, your body usually, not always, usually can naturally make enough melatonin. But it's something to think about. What other questions? And Rebecca, thank you. She put my email in the chat.
Yes, thank you so much, Dr. Asher. If anyone does have any questions, feel free to put it into the chat, and Dr. Asher, I can read it out loud, or you can unmute yourself and they'll just indicate to me that you do have a question. We can call on you. We do have about 5 minutes left for anyone with any questions. And yes, if you're interested in any of the trials or the program that Dr. Asher mentioned, his email is in the chat as well.
So if you do have a question or comment, if you want to just unmute or just raise your hand, by all means. And otherwise, again, I know this was a lot just for a brief 1-hour session, but I hope it just gave you a little insight into some of the things that we talk about. Thank you all so much for your attention. It's always fun for me to take a break from the clinic and speak to the people that we're doing this all for. And again, I wish everyone much health in the new year and the days to come. Thank you all so much.
Sarah, you had a question?
Yeah, a quick one. I have not been affected so much by bad sleep, but forever I've had my windows wide open and shades wide open for my whole life sleeping. Would my sleep, should I consider drawing my shades at night so it's dark?
You know, the first piece is if you're doing well on the sleep arena and you're waking up refreshed and you're not generally having a hard time with falling asleep or staying asleep, I would argue I wouldn't, you know, practically speaking, think you need to change anything.
Okay, good. Thank you.
I have a question. My sleep doctor recommends that if I can't sleep, to get up and do something like go in the kitchen or whatever. But to me, it's like I'm so exhausted. I'm afraid I want to fall and collapse. So can I just like sit up in bed and turn on the lights and do something instead of getting up and get walking?
Well, first things first, if there are any safety concerns, and that's why I often don't suggest the stimulus control theory for people who are in active chemo, like if there's a concern for a fall, that takes precedence over everything, right? So that's that. But the reason, and I mostly agree with what your doctor said, the reason why we want you to get out of bed and go to another room is not to get to the other room and do something active. Actually, what you should do, assuming it's safe, is to go to another room and maybe just, you know, meditate or pray or listen to some soft music, not something activating like washing the dishes or doing laundry or paying the bills or getting online and turning the lights on. But again, the reason for that I didn't get a chance to go through in great detail is, again, subconsciously to avoid the neural association of being in bed and being awake, right? He wants you to be awake, or she, in the kitchen, so that you learn subconsciously that the bed is just for sleep. Again, if there's any safety concerns whatsoever, this all goes out the window, and I would put that first.
Thank you.
Of course.
Dr. Asher, you mentioned about meditation helping to reduce stress or even sleep. Do you mind to talk about how that works or how that can help?
Well, mindfulness has been shown to help some people some of the time. So it doesn't, right? So nothing works usually for everyone all the time. But for many people who have racing thoughts, particularly, so we've all heard this, right? We put our head down and it's like 1,000 thoughts are going through our mind and I just can't quiet my mind. That's in many ways one of the beauties of mindfulness is, right, ultimately, and I'm not the expert, but it's about, you know, not being judgmental of our thoughts, right? It's being less reactive, it's observing, and that process, again, often reduces the sympathetic nervous activity, and in the long run, as a byproduct, may help enable better sleep for many people.
I have a question or a
Yes,
statement. No, what I found when I was really going through chemo and radiation, that if I got out of bed and went to the family room where I have a recliner, I was able to go to the recliner and begin to sleep. And it worked for me just to switch that environment.
Mm-hmm.
Right, and again, I don't want to stop anyone. If anybody has a system that works for them in terms of it allows you to get restorative sleep, and one of the key goals is waking up, hopefully waking up refreshed, I wouldn't interrupt those strategies that are working for you. Great.
Thank you.
Judy, last question.
Could we go back to exercise? You were talking about the large number of minutes per week that a person would need to exercise. Personally, and I know from my association with other people here at the Cancer Support Society, not many of us could do that much exercise. The treatment is quite debilitating. And so I was wondering if you have considered that and made any allowances or maybe ideas of how we could have taken care of the idea of the exercise, but knowing that we weren't capable of that amount or even very much.
That's a very important point. I want to emphasize a couple of ideas that I hope will make sense. So number one, and I can't emphasize this enough. It is that 150 is not some magical black and white marker. So even 10 minutes, even 20 minutes a week, they've been, and I wish I had the graph to show you because I have it in my mind. It's been shown to have meaningful improvements and impacts over 0 minutes a week. And 50 minutes a week has meaningful impacts over, 10 minutes a week. So it's not an on-off switch in terms of it being black and white, number one. Number two, it's also important to realize that those suggestions were for moderate exercise. Now, what does that mean? And the reason this is important is because what's moderate for Mr. Smith and what's moderate for Mrs. Jones may be completely two different things. And one rule of thumb you can take to help you figure out what that is the so-called sing-talk test. And the brief version of it is, if I can't talk in a sentence because I'm huffing and puffing with just a short sentence, that means it's too intense for where I am right now in the middle of chemo, in the middle of radiation or whatnot. So even a few minutes of whether it's walking or a gentle stationary bike, or some people might have arrangements for some home physical therapy or outpatient physical therapy if that's appropriate for you. Anything that involves you just moving your body a bit can make a difference. And again, it is not all or nothing. So even 30 minutes, 60 minutes, whatever you can get will make a difference.
Thank you.
Thank you
Yes.
so much, Dr. Asher.
Rebecca,
Yes.
can I ask one thing? Will Deneen and Rosemary L. read the chat questions I sent to them? I know them both, so
I-
thank you.